So can we start it, sir?
Yes, ma'am. Sure. I'm
Yes,
ready.
sir. A very good morning to one and all. Myself, I'm Dr. Divya Lakshmi, Assistant Professor of Physiology, Sri Ramachandra Medical College and Research Institute, and I will be the host for today's session. Before we begin, I would like to give you a brief overview of Research Toolkit 101. Research Toolkit is an introductory session designed to simplify the fundamentals of research for beginners. Organized by the Department of Physiology, Sri Ramachandra Medical College and Research Institute. This session focuses on building a strong foundation in basic research concepts, helping participants understand how to approach, interpret, and engage with research in an effective and ethical manner. The session has received diverse registration across discipline, ranging from fashion technology and allied sciences to medical and health sciences, underscoring the universal relevance and the research skill necessity of research skill across disciplines. To guide us through this journey, To guide us through this journey and help us build a strong foundation in research, we have with us Dr. Umesh Vadkavas. Umesh sir is a public health dentist and bioethicist with over a decade of experience in academic, research, and clinical practice. He is a published author with more than 50 research papers, including several systematic reviews, meta-analysis in high-impact journals. He has also delivered over 50 guest lectures on research methodology, biostatistics, evidence based dentistry, and research ethics across India. Today, Dr. Umesh sir will be talking to us about the basics of study design, a foundational topic that is essential for understanding and conducting a quality research. With his strong background in research, teaching, and public health, Dr. Umesh sir brings us valuable insights and practical expertise to today's session. Please join me in warmly welcoming Dr. Umesh Vadkavas. Over to you, sir.
Thank you, ma'am. Thank you. Uh, can
Shall I
I
stop
share?
pressing? Yes, I'll stop
Yeah.
presenting mine.
Yeah. Uh, I want to know first whether my presentation is visible, ma'am,
Yes, sir, it's visible, sir.
and my audio is clear.
Audio is clear, sir. Can you slide
Yeah.
the show us change slides, sir? Ah, yes. Okay.
All right. Right.
Yes, we're good to go, sir.
So, shall we start the presentation?
Yes, sir, you can start, sir.
Okay. Uh,
The
Very good
participants,
morning. Yeah.
50 of them had registered, sir. 26 have joined. Uh, if we
Shall we
can,
wait for 5 more minutes?
yes, sir, we'll wait for 5 minutes. Okay, sir.
Yes, yes. So till then, I can have a brief conversation. Is
Yes.
is chatting permitted in this
Yes, sir,
Google Meet,
totally, sir.
ma'am?
Your call, sir. Yes, chatting permitted. How are
Yeah,
you?
yeah,
Your
yeah.
convenience.
Good morning. This is Dr. Umesh Vargave. I'm a public health dentist, and I've been involved in research for more than a decade, and I keep delivering lectures, workshops related to this. So very less often I do deliver lectures online. Most of the times my lectures are offline. However, uh, online lectures are quite feasible. We can attend these lectures at our own comfort. So I think around 24, 25 people have joined here. And may I know how many of you are postgraduate students? Can you just write PG in the chat box? Just wanted to know, like, are you students or are you faculty members? Just if you are postgraduate students, can you write PG? Yeah, that's good. PG, PG, two people. Great, great. Dr. Ramya, Dr. Jemmy, postgraduates. 29 joined. Aishwarya, welcome here. So should I assume that rest of you are faculty members? Can, if you are faculty, can you just type F? Great, great. Good morning, Dr. Divya Lakshmi, Dr. Sangeeta, Dr. Linga Devi. Good morning. So, may I know how many of you, of course, faculty might have attended these workshop earlier also, but how many of you are attending the research designs for the first time? Can you write FT in the chat box? If you're attending the workshop or a lecture on research designs for the first time. Okay, 3 people, FT, 4, 5. Great. There are quite a few of you who are attending this presentations for the very first time. So now I think we are at 9:10. So shall we start the our presentation?
Yes, sir, we can start the presentation.
Yeah. Just a second. So it's visible now. I'm going to start the lecture. Right.
Yes, sir.
Uh, Research design, which we are going to discuss this morning, is a very basic and a fundamental concept involved in executing the research. Every research has three important components, or we can say the designs. One is sampling design, another is research design, and third is a statistical design. Sampling design You might have heard about the different sampling techniques, sample size estimations, and etc. That's what we discuss about. Research design is the entire plan or the blueprint by which you execute your research and collect the information from the patient or whatever the subjects you are involved in. And finally, the statistical design. This involves, once you collect the information, how you going to analyze it, test it, evaluate it, and etc. for a better interpretation and or extrapolation. Among these three major components of your research designs, when you submit your protocol, if you are a first year postgraduates, when you submit your protocol, you have to divide your entire protocol into these three types. One is what is sampling methodology, what is sampling design, what is research design, and what is statistical design. If you are clear with these three designs, then your entire the plan of execution of research goes very smooth. So today we are going to deal with research design. Design matters because it's a blueprint. Many times we have observed researchers doing the research without giving much deliberation into the planning. And this will cause a lot of confusion at the later stages, during execution stages, during data analysis stages, during interpretation stages, during justification of the technique, whatever we are employing. So it is very essential that you spend a lot of time in planning your design, then execution. So it is a designs which helps us to get results which are valid, reliable, and ethically sound, so that we can influence human lives in a more positive and a practical ways. Before I dive into these presentations, we need to understand few basic important concepts or terminologies, which I'm going to use it in the entire presentation. The first terminology is a variable. We repeatedly use this term variable in the entire presentation, or even when you are writing your research, you use this word. Variable is anything which varies within a person from time to time, or something which varies from person to person. For example, the blood pressure. The blood pressure may vary within a person from time to time. Morning, I might be having different blood pressure, afternoon, and then in the evening. So, at the same time, the blood pressure may vary from person to person also. There are so many things. The eyesight varies, the blood pressure varies, the height, weight, etc. Those all are called as variables. The entire research is carried out to prove the causality. Causality in the sense, we conduct a research to prove that A causes B. In a sense, paracetamol reduces fever. Contaminated food causes diarrhea or something like that. So there is a cause and there is an effect. The cause is called as independent variable. Contaminated food causes diarrhea. Here the contaminated food is a cause. It is also known as independent variable. And the diarrhea is called as dependent variable. You have to remember these points very clearly, so that you can understand the next slides in a better way. Independent variable is a cause. Smoking causes lung cancer. Smoking is an independent variable. Dependent variable is a lung cancer. I hope you understood it. And at the same time, there is some third variable is called as confounding variable. Confounding variable which influences both cause and effect. Let me give an example to you that there was a research which was carried out which says that the shoe size is associated with the IQ of a human being. The result said that person with bigger shoe size will have higher IQ. So here the independent variable is the shoe size. The dependent variable is the intelligence quotient of a human being. Do you think the shoe size will determine the intelligence quotient? And sometimes the research gives you such a spurious or a false associations. This happens because of a confounding variable. What is confounding variable? The confounding variable is age. The people who grow older, generally the shoe size increases. And as they grow older, their IQ also increases. And you may falsely claim that the shoe size is associated with the intelligence. So this hidden variable, that is the age, is a hidden variable, which is called as confounding variable. And confounding plays a very, very vital role in the entire research. So suppose if you think that a, a disease will lead to the bad smell from a human being, you feel that disease is causing the bad smell. But there is a hidden variable called as germs, microbes. The microbes are the one which is causing the disease. The microbes are the one which is causing the bad smell from a human being. But disease as such directly not causing anything is not related directly to the bad smell. So you have to understand there are several hidden variables which are hidden, which you require a thorough understanding of the biology, causology of the disease so that you'll understand what is the confounders. I hope you are following my explanation. Whenever we carry out a research, we carry out a research on a sample. We take few subjects. Let's say you are doing a research on subjects with tuberculosis. You are not going to include all the patients in the world with suffering from tuberculosis. No, you're going to include some 100, 200,000, 10,000, whatever the size you want. A subset of the population that is called sample. From a population, you extend the sample, you carry out the research from the sample, and whatever results you get, you try to generalize or extrapolate to the population. This process is called as generalizability. Let's come to the main topic, that is types of research. There are different types of the research we perform in our day-to-day research process. Like basic versus applied, observation, experimental, quantitative, qualitative, primary and secondary. Will go one by one. Basic research and applied research. The basic research is carried out to understand the basic mechanism within a human body, or for that matter animals also. Like let's say Department of Physiology wants to know how exactly the RBCs attracts the oxygen and how exactly the RBCs depletes the oxygen. Okay, so that understanding the mechanism of attracting the oxygen by the RBCs, that type of research is called as a basic research. However, if I want to do applied research, I want to know what will happen if I give a concentrated oxygen to the human being, how much of oxygen RBC carries. So I'm changing the environment. I'm applying something and looking at the outcome. This type of research is called as applied research. Basically, 90%, or I can say 95% of the research we do carry out on our in our post graduation is applied research, and very few people, maybe from the basic science research like anatomy, physiology, biochemistry, biology subject experts do carry out the basic research. Another is called as observational research versus experimental research. Observational research is nothing but here researcher is just observing what is happening in the nature and making a note of it. Okay, let's say like you want to see how people, how young people in India are able to run, how fast they are able to run. So you are making the like time points of different people. Like somebody ran 100 meters in 2 minutes, somebody ran 100 meters in 30 seconds, and etc. Just making a note of that. You are not doing anything, you're just recording the values. However, you thought about manipulating this. How you want to manipulate? You offer them with the shoes and want to see how fast they can run. So if you are manipulating the nature and trying to see what is happening with the dependent variable is nothing but the outcome variable. Then such a type of research is called as experimental research. Okay. So today when we are discussing on basically about observational research and the experimental research. In the observational research, a researcher is just observing the nature and making a note of it. However, in experimental, he's not just observing, but he's also manipulating the nature and making a note of that. Another is quantitative research and qualitative research. When outcome of your research is measured on a scale, let's say the height, weight, blood pressure, whatever it is. If you're measuring something a quantitative value, then it becomes a quantitative research. However, if the outcome of your research is a qualitative, if I say that, how was your experience about this online webinar on research designs? Tomorrow, when your faculty asks you, then you give a verbal feedback to your faculty whatsoever. Like it was good, but it was long, it was a bit less interactive, and etc. etc. Whatever it is. Then that type of outcome you are recording, that becomes a qualitative research. But if your faculty asks you, rate this webinar from 1 to 10, 1 is very poor and 10 is excellent, then you're going to give me a marks from 1 to 10, like 7, 6, 8, 5, whatever it is. So then it becomes a quantitative research. Okay. And finally, primary research and secondary research. The primary research is research where researcher directly collecting the data from the patient or a sample. That type of research is called as primary research. However, the secondary research involves the data is not collected. Like you have some records in your department, or there are records on a digital platform. You are accessing those records. It is recorded to somebody else for some other purpose, but you're using that existing information for your research purpose. Such type of research is called as secondary research. Even the systematic review and meta-analysis falls in secondary research. Okay. When we understood the basic now, what is variable, what is independent variable, what is dependent variable. We understood all these three. And also we understood the confounding variable. Confounding variable is a hidden variable which can influence both cause and. Next, we discuss about different types of research: basic research, applied research. Basic is understanding the mechanism, applied is changing the environment and seeing the outcome. This is applied research. Observational research and experimental research. In observational research, a researcher is observing and making a record of it. In experimental, he is manipulating, adding something or removing something from the nature and checking out what is happening. That's a experimental research. And then quantitative research and the qualitative research. If the outcome, what you are measuring, or dependent variable is measured on a numerical scale, then it becomes a quantitative research. But if you are just assessing the quality of the dependent variable, then it becomes qualitative research. And finally, the primary and the secondary research. The primary research is where the researcher himself or his team members are extracting the information from a patient or a sample for the purpose of research is called as primary research. However, if a researcher decides to use the existing information in the records or the samples which are already there in the department or on the digital platforms and using that information for their research, that becomes a secondary research. And one of the popular nowadays, the secondary research is systematic review and the meta-analysis. With this, we are diving into the specific research designs. The research designs are fundamentally classified into observational research and experimental research. That's what we discuss. In observational, we are just observing. Let's say that I want to know that who are more talkative, boys or girls. Okay. I argue this with my wife, so I always take this example to show some evidence to her. And you know, right? My wife never listens to my evidence and she keeps arguing with me. Anyways, this is a research. I'm just observing the number of words spoken by men, the number of words spoken by women in a day, and making a note of that. I'm not telling anything, I'm just observing them. So that type of research is called as observational research. Now coming to the experimental research. Here researcher is manipulating something, changing the nature and checking out what is happening to the outcome. Let's say this is an example where the red markings recently on national highway in Madhya Pradesh, in a forest area, they have marked the roads with red color to warn the people that it's a nature area where animals can cross the roads. You have to be very careful and drive slowly. So we are changing something on a road and checking out what is happening to the nature or what is happening to the accidents with animals. So this is called an experimental research. Here the researcher is not just observing but manipulating the process. I hope you got it. The observation research have two types. One is descriptive research, another is analytical research. In the experimental, we have randomized control trial and non-randomized control trials. So let's focus first on observational research. In that, okay, coming to the hierarchy of evidence, every research design generates some evidence, the research evidence, and every design has some credibility or hierarchy in evidence-based medicine. The, the information collected from the observational research is considered inferior to the experimental research. So the rule of the thumb is that whenever you can do the experimental research, don't do observational research. I'm telling it once again. Whenever you can do the experimental research, don't do the observational research. Because the evidence generated from the observational research is considered less credible than the experimental research. And the second research, which is, as I told you, the systematic review meta-analysis holds the highest level of evidence. The secondary research is only and only possible only when we have the primary research, experimental and observational research. Right. Let's come to the observational first. As I mentioned you, there are two types. One is descriptive research, another is analytical research. Descriptive research is a research where we describe a sample. I will take the participants in this webinar and then check out how many of them are faculty, how many of them are students, how many are attending the lecture for the first time, how many are already the experts in this area, and all this stuff. Describing a sample is called as descriptive research. Let's say that I'm just checking out the nutritional value of a plate of idli. So I'm just telling this is the protein is this, carbs is this, etc., and calories is 102. It's just describing one sample is called as descriptive research. However, when you try to compare the one group of sample with another group of sample, let's say I told you like I want to compare who's more talkative, men or women. When I'm comparing a group of men with a group of women, when comparison comes, then it becomes analytical research. You have to understand it's a very, very fundamental difference between descriptive and analytical. In descriptive study designs, there is no clear-cut comparison groups in the beginning of the research. However, in analytical research, to begin with, you have cases controls, group A, group B, and etc. So here I am comparing the idli with medu vada and comparing the calories. Okay, this is a very fundamental difference between descriptive and analytical. The another difference is that descriptive research generates idea. Analytical research tests the idea. What does that mean? Generates whenever you do a survey. One second. Whenever you do a survey, you get lot of ideas. Let's say during the COVID-19 pandemic, there were a lot of surveys being carried out among the people in the airports, in the whatever, in the different localities and etc. They were going, checking the different people and trying to find out that who is affecting the more. Then later on, they realized that after some time that doing a survey, people with comorbidities like diabetes, cardiovascular disease, or some immunosuppressive diseases are more prone to what do you say the COVID infections when compared to the healthy people. So this gives an idea. This is generating the idea. They are not confirming it. Okay, like what is happening to the men and women, what is happening to the young people and old people, what is happening to the newborns, what is happening with morbidity, without morbidity, and etc. etc. What is happening to people who are living in urban areas? What is happening to people living in a what do you say, rural areas, etc. etc. There's so much surveys being carried out and generating different ideas out of it. But if you want to prove that, if you want to test that, then you have to go with analytical research. If you want to know whether exactly the diabetic patients are more prone to the COVID infections, then what you have to do is that you take a group of diabetic patients and a group of non-diabetic patients and check out whether they have developed the COVID infections or not. Then you can prove or disprove whether both are associated or not associated. This is a fundamental difference between descriptive and analytical research. Coming to descriptive research, there are different types: case reports, case series, surveys. And the surveys, we have longitudinal survey and a cross-section survey. We'll go one by one. Case report is a very basic type of study design where we usually uh, present a single rare, unique, interesting case which you come across in your day-to-day clinical practice or even a field surveys, and you present to the world because it's very rare. You rarely see such type of issues or conditions or the treatment modalities, and you want to inform to the globe or the scientific people that this can happen, this is can be treated in this way, etc., etc., etc. So I have taken one example for here: potential lethal course of a nasogastric tube, a case report. So the nasogastric tube intubation is a very common procedure in the ICU, and where during this it's a safe procedure, but sometimes a rare event has happened here where that tube has pierced superior vena cava and passed into the right atrium and caused a very dangerous complication. So such a complication, you want to tell the world that this can also happen, and you have to be very careful. This is one type of the case report. And when you have multiple case reports on similar condition or similar diagnosis or similar treatment procedure, then that is called as case series. Okay, coming to the surveys. Coming to the surveys, generally the survey is done on a group of people. Can you see? If you see in the picture, a nursing professional is surveying the people who are in the airport, checking their body temperature, checking their oxygen levels. So what she does is the population is traveling in the airport as a population, and she is checking for their body temperature and blood oxygen levels as the results, and then finally drawing the conclusions. What conclusions she may draw? She may draw saying that old age people have a lower oxygen levels than the younger age. She may also conclude that people traveling from certain areas of from part of the globe are more prone to oxygen depletion than other people. And she may also conclude that we are observing that body temperature is not very much related to the blood oxygen level. So all these ideas she is going to generate from that survey. This is called as collecting the information from the population, analyzing that data from and generating the results and interpreting it in a very scientific and logical way. That is the purpose of descriptive surveys. Remember that descriptive surveys throws light on existing condition. It does not have any scope of explanation. It cannot tell you that why it is that from a certain part of the world, people are more prone than other part. You may have different hypotheses, you may have different theoretical explanations, but doesn't confirm that explanation. For that, you have to go on to the next type of research business. And to begin with, there is no comparison group in the surveys. It's the entire population. People who are in the airport is the entire population. There is no clear-cut group like who's are traveling to the international, who are traveling to the local. I'm going to compare it. No, nothing like that. It's just people in the airport, and it generates a hypothesis. Hypothesis is nothing but the ideas in your research. Many of times, people do ask me when I go for a workshop that, sir, how to choose the research topic. You can choose a research topic just by reading a surveys on an area. Let's say you are a postgraduates in cardiology, go through different descriptive surveys published. and they conclude with different what do you say, like males are more prone, people with diabetics are more prone, people on steroids are more prone, and etc etc etc. And that topic you can choose because that generates a hypothesis. So I'm just like, a survey was done to check out the digital content use among new medical graduates. Okay, so nowadays the medical graduates are using it. I want to know, like, do they really consume the digital content? Yes or no? So what they consume for the medical treatment and diagnosis, or just for the entertainment purpose? If they consume it, where do they search for? Do they search the answers on a Google, Facebook, Instagram, or on a reliable databases, scientific databases like PubMed and something else? All this type of surveys are a descriptive surveys. If you're carrying out a survey at one point of time, if I am doing a survey on a medical graduates about using the digital content at one point of time, then it becomes a cross-sectional survey. If I'm going to examine them after every year and year, after postgraduates completing, what were the use of digital content after 1 year, 2 year, 5 years, and whatever it is from the graduation, and how the usage of the digital content is been changing, then it gives me a trend in a digital content that becomes a longitudinal survey where we have multiple follow-ups. Okay, so longitudinal survey is data is collected at more than one occasions, and here we come across incidence. Incidence is like, I think you remember studying this incidence and prevalence in undergraduation. Okay, so incidence is new cases, prevalence is old plus new cases. So only when you follow up, you will come to know that how many of them, the patients, has developed the condition. So new cases, and also you understand the trends of disease. Whether the, let's say I want to know, like, from 2020 to 2025, what is happening to the COVID infections. Obviously, the COVID infections increased first and gradually starts taper down. I think it's very, very low now. So that is how you'll understand when you follow for a very long period of time the trends of disease. The only problem here is that it is called as attrition. The attrition means many times you may not follow up the people because the patients may migrate, the patient may die, or patient are not interested to participate in your research, so there is loss to follow, and it requires a lot of resources in the longitudinal survey. Cross-section survey just one time is cheap, and it can give you the immediate answers. So we are done with the descriptive research. Let's summarize it. Descriptive research is describing a sample or a group of people. There is no comparison group to begin with. Descriptive research generates idea but doesn't test the idea. And there are different types of descriptive research: case report, case series, surveys, and the surveys we have cross-sectional survey, we have longitudinal survey. Remember that whenever you don't have a clear-cut idea on a certain topic, the topic is just emerging, it is better to start with the descriptive research and then move to the analytical. If a topic is already mature, a lot of research has been done on a certain area, then it is better to go with analytical than a descriptive research. And another important thing is that descriptive research uh, provides very low level of evidence, and hence it is quite difficult to publish it when compared to the analytical research. When a publication perspective, I'm just saying, sometimes you find difficult to publish your case report cases. Nowadays, it is very, very difficult to publish your case report and case series. Doesn't mean that you should not do the case report. Probability of publication decreases. Okay. However, let's move on to the analytical research. I assume that you people are able to follow me and you can hear me very clearly. Okay. Any given point of time, if you are not able to hear and understand what I am saying, please stop me. Coming to the analytical research, as I said that comparison is mandatory. You have to have a study group and a control group, cases and controls to begin with. And you are going to test the idea or generate or test the hypothesis, not generate the hypothesis. Most of the times, analytical research is carried out to test the hypothesis or idea. Comparison is mandatory. and it tests association, also the strength of association. What does that mean? Let's say that uh, what are the risk factors or association of tuberculosis? Tuberculosis is more prone among malnourished people, more prone among people suffering from immunodeficiency disease, more prone among people living in very areas where low socioeconomic status and etc. These different variables are associated with the tuberculosis. It can be the malnourishment, it can be the immunodeficiency disease, it can be because of the lower socioeconomic strata. Everything is associated with the tuberculosis. But you also want to know the strength of association. What is strength of association? Let us say that you are a researcher and you are an expert in tuberculosis and you want to reduce the tuberculosis from India, and you approach to the policymakers or the politicians or whatsoever bureaucrats and approach them, and you say that, sir, these are the three: nourishment, social status, and immunodeficiency disease is causing the tuberculosis in the society, and I want to reduce it. He says that among these three, which one is greatly affecting it? Because I can't work on all these three. I don't have the budget or resources to tackle all these three things at one point of time. I have to prioritize one thing. Which one is strongly associated with tuberculosis? Is it nourishment? Is it immunodeficiency disease, or is it socioeconomic status? Then only when you understand the strength of association by doing a research, then you can give the answers to them, sir. Why? If you control over nutrition, you can reduce 3 times. If you control over immunodeficiency disease, you can reduce it by 2 times. And if you control over socioeconomic status, then you can control this disease by 5 times. Something of this sort, if you give the solution, then the policymaker can make a decision about it. That is where the strength of association concept comes in. There are basically 3 types of analytical study designs. One is cross-sectional, second is case control, and third is cohort. If you want to understand these 3 concepts, you have to understand what is independent variable and dependent variable, which we have discussed earlier. I want to tell you here is that in my experience of more than a decade, most of the researchers, even the senior researchers, get confused in analytical study designs, especially among these 3: cross-sectional, case control, and cohort. If you understand the fundamental difference, then you will not make any errors in it. Let's go one by one. You know what is independent variable, you know what is dependent. Independent is cause, dependent is the outcome. When you're measuring the independent variable and dependent variable at one point of time, then it becomes a cross-sectional study. Let's assume that you think that HIV infected people are more prone to tuberculosis. That is what your hypothesis is. That is what your idea is. And you want to know it. HIV infected people are more prone to tuberculosis. What you do? You take a group of people, check their HIV status then and there, and check their tuberculosis infection then and there. Both HIV and TB. HIV is the independent variable, tuberculosis is the dependent variable. You are assessing both HIV status and tuberculosis condition at the one point of time. That means to say that is a cross-sectional study. That means to say it is a cross-sectional study. However, if you want to do the case control study, what you do is that if a patient reports to you with a tuberculosis, you will ask his HIV status of the past, the way we do in our departments. Whenever a patient comes to us and he complains of so and so problem, we ask the history about it. Are you a smoker? What is the type of diet you consume? What is the different types of the problems you have encountered? What are the different types of medications you have taken, and etc. etc. So what we're doing is we are going back in the history and collecting the information about the past. So the condition has already occurred. The person is already having tuberculosis. And what we are doing here is that we are asking about the past. We are going back in the time. So that means to say it is a retrospective study or a case control study. Retrospective in the sense moving from disease to the cause, outcome to the cause. That was is the case control study. However, if you want to do a cohort study, you will identify people recently diagnosed with HIV, and then you're going to follow up for a certain period of time, year, 2 year, 5 year, 10 year, whatsoever, and check out how many of them is going to develop the tuberculosis. So what you're doing here is that you are moving from cause, you are identifying people with HIV in cohort. However, in case control, you are identifying people with tuberculosis. There's a very fundamental difference. So when you identify people with HIV and following up with in the future, in coming time, then it becomes a cohort study. Okay. If both independent and dependent variables are assessed at one given point of time, it becomes a cross-sectional. When you study the dependent variable first and then ask the history about the independent variable, then it becomes a case control study. When you identify people with the cause, like HIV infection, and follow up them in the future to check out whether they develop a tuberculosis or not, such a study design is called cohort study design. Okay. So I'm just directly jumping to the case control. See, in the nature, cause comes first, disease comes later. You all agree, right? Smoking comes first, lung cancer comes next. Physical inactivity comes first, obesity comes later. HIV comes first, tuberculosis comes later. Generally, that's what I'm assuming. It may be other view also. People with can also have HIV. That's a different thing, story. So generally, we believe cause comes first and goes with disease. However, in the case control study, we identify people with the outcome, like with lung cancer, without lung cancer, and check out are they smokers? Do they have a history of smoking? What we are doing is asking the history about the independent variable. That is the reason it is also called as retrospective. See, the direction is back because we are moving back. That's retrospective design. First, what we do in case control is based on the outcome. With disease becomes cases, with lung cancer become cases, without lung cancer becomes control. Okay, we'll identify a group of people with lung cancer, group of people without lung cancer, and check out among the people with lung cancer, how many were the smokers that is exposed, how many were non-smokers. Similarly, in the control group, which is a healthy individuals with no lung cancer, how many were the smokers and how many were the non-smokers. And we compare them and we reach to the conclusion. When we compare this data, we reach to the conclusion. What you have to understand here is that we are moving from dependent variable or the outcome variable towards the independent variable. Okay, that's a retrospective case control study. So these are the four fundamental concepts you have to understand when you're taking the case control. One is selection of cases and controls, matching, measurement of the exposure, analysis and interpretation. Okay, let's go one by one. See, cases and controls. What they say is that if you are identifying a person with, what do you say, the lung cancer as a cases and without lung cancer as controls, there should be a operational definition of the uh, cancer. I'm going to say lung cancer is a very, very broad term. There might be different types of lung cancers, different stages of lung cancers, and etc. What exactly the type of the patients you're going to include in your research? Are you going to include stage 1, stage 2, stage 3 lung cancers? Are you going to include the malignant lung cancers or benign lung cancers? I don't know. I'm not an expert in that area, but I'm just imagining the way it can be. whatever the type of the cancer patients you want to include. Are you going to include the cancer patients without any other problems? Like he should not have any other history of alcohol consumptions or history of some other thing. So something like that. Whatever you want to have inclusion exclusion criteria, there's a cases. At the same time, the patients without lung cancer should be selected as a comparison group because it's an analytical study. So one thing you should remember whenever you are selecting the controls, controls should be similar to cases in all respect, but for they do not have the disease. Let's assume that in cases with lung cancers, the mean age group of the subject is around 65 years. However, in the controls, can you take 25-year-old people without lung cancer? No, there is a huge difference. You should take approximately 65-year-old people without lung cancer. Let's say that in cases, around 90% people were male subjects. Can you take in the controls more than 50% as a females? No. The control should be more or less similar to the cases, just that they do not have the disease. Rest as many variables as possible, they should be similar to the controls. The process of matching, okay, that process is called as matching between cases and controls to make them comparable. Like compare apples with apples, not apples with orange. That's what it said. That's the process called as matching. Okay. So control should be matched to cases to avoid something called as confounding variable. You already know what is confounding variable. If there are confounds, that will yield you the false association. So by matching, you are reducing the confounding. Confounding is a bias, which are going to control in this research. Okay. Generally, uh, I give a hands-on activity when I am in offline workshops about the odds ratio. That's the statistical part which tells the strength of association that was discussing. If I want to know, like lung cancer can be caused because of smoking, because of malnourishment, because of some chemicals, because of other conditions. Okay, then I want to estimate the strength of association. If I want to estimate the strength of association, there is a numerical value to that that is called as odds ratio, which is calculated in the case control study. So I don't want to go into the calculation. I just want to tell you that if the odds ratio is 1, if the odds ratio is 1, the risk is same among cases and controls. If the odds ratio is more than 1, then the risk is more among the cases. If odds ratio is less than 1, then it means to say the risk is more among the controls. Okay, let's not get into too much of it, but I'll just tell you example here. I estimated the odds ratio of 3.6. I want to check out the association between the HIV and tuberculosis patient, or odds of having a tuberculosis and HIV patients. Then I got the odds ratio 3.6. I'm going to interpret this as the HIV positive patients are 3.6 times more prone to TB than HIV negative individuals. That is how to interpret it. Okay, if you're getting 3.6 times, then it becomes more practical to understand the strength of association between the two variables, that is HIV and TB. Okay, the problem with what you say case control study is something called as selection bias. If you fail to match cases and controls, then there is problem called as selection bias. You are taking the patients more than 65-year-old as a cases, and you taking the subjects who are less 30 to 35 years in the control, then obviously there is a bias in the selection of the subjects in case and controls. And once there is a bias in selection of cases and controls, that will lead to the confounding bias. A third hidden variable, the age can play as a hidden variable which can influence the outcome. And another problem is a recall bias. Asking history, whenever you ask a patient like how many cigarettes you used to smoke 1 year back, 2 year back, is it one packet or two packet? He may not remember it. And we also face this problem during examinations. Okay, if you relate better, I think. Whenever you take a case history in your examinations, The patient says you something, and by the time the external examiner comes and inquire the patient, he'll tell you the different answer itself. He does that because he don't remember. He's bluffing. There's a problem with the case control study. Whenever you are asking a history, there is a probability that many of the people bluff it or give an approximate value. They are not very sure about it. Okay, so that is called as recall bias. Now, another problem is temporality cannot be established. What is temporality? It is which came first. Let's say that a patient came to you with a, what do you say, with a complaint of tuberculosis, and you are asking a history of HIV. How do you know that whether HIV came first or tuberculosis came first? You never know. Sometimes it is the opposite way also. The patient might be having the tuberculosis since long time, maybe it is mild, and in that process he encountered the HIV later on in later stages of the life. But now since he's having an issue, he has reported here. So in case control study, you cannot establish temporality, which came first. For temporality, you have to opt for cohort study designs. So this is a very one of the most important limitations of case control study. And the advantage is relative to easy to carry out because you identify a group of people with disease, without disease, ask the history at one point of time. As a reason, it is rapid, inexpensive, and easy to carry out. The another advantage of case control study is multiple risk factors can be identified. If you identify, take a group of people with tuberculosis as cases and without tuberculosis as controls, not only the HIV status, but you can also have the history of smoking, history of alcohol drinking, history of their genetic background, their nutritional status, their physical activity, and many more things, medicines they are taking. So you can identify the multiple causes with just what do you say, was for the one disease. And there is no attrition or loss to follow because you are just collecting the data at one point of time, not at the multiple point of time. There is no attrition loss to follow. Suitable to investigate the rare disease. What is the rare disease? Let's say that during COVID time, there are many subjects who are, like very few subjects are developing a problem called as mucormycosis, the necrosis of the maxillofacial bone because of fungal infections. This was happening, mucormycosis. It was quite rare. If you want to do a research to identify the cause of mucormycosis, which is happening in 1 in 10,000 people, then what you better do is that you identify a group of mucormycosis in a tertiary hospital, like 30, 40, 50 cases. If you get it, you're lucky, and try to find out whether they had a COVID infections or not. Rather than following tens of thousands of COVID patients and checking out whether they are going to develop the mucormycosis or not, which is more feasible. It is feasible is the case control study. Okay, and you're getting my point. Let's move on to the cohort study design. This is an ideal study design when you are planning to check the etiology or association of a risk factor with outcome. Please make a note of that. If somebody asks you which is the most ideal study design, if you want to prove the etiology of a disease or a risk factor of a disease, then that is a cohort study design. Okay, because it is going as a nature is going. It is moving from the cause towards the disease. That is how the nature happens. And that is the reason we call it as prospective cohort design. Okay, or prospective study design. So in this study designs, we examine the association between exposure and outcome by assembling first those who have been exposed or our study group. Let's say people who are smokers, are study group, but they didn't develop the lung cancer yet. They are just the smokers in the society. You identified them. They become study group. And control group was similar to the study group, but they are not smokers. Their age group, their gender, their lifestyle, their socioeconomic status, their nutritional status, and etc. are more or less the same. They are not smokers. They are the controls. And when you recreate these people in your research and follow them both study and control group for a few more years in coming years and check out whether they develop lung cancer or not, that becomes a cohort study design. Okay, that's what we do here. We identify the first smokers or exposed as cases, non-smokers as controls, follow for certain period of time, and check out whether they are developing the disease or not developing the disease. That is outcome variable, and then compare. Then you come to know uh, whether the risk is more among the cases or the controls. So sometimes the cohort redesigns is of three types. Okay, just a second. Sorry. Sometimes the cohort study designs are of three types. One is called as prospective, retrospective, and combination of prospective and retrospective. I don't want to confuse you here, but one thing you have to remember that cohort designs always moves from cause to disease. It never moves from disease to cause. You call it prospective because you identifying people with smokers, following up with certain period of time and checking out whether they develop a disease or not. This is called as prospective design. It is also called retrospective because sometimes, let's say that you have a record of a patient who is visiting your hospital for last 10 years. And now at this 10th year, you decided to do a research that I want to know whether smoking causes lung cancer or not. Then you can do one way that this patient is a smoker. I'm going to follow up him for the next 5 years or 7 years, whatever it is. However, you might have records of him in the earlier records, like since 10 years records. You can go back, check out, was he a smoker 7 years back? Was he a smoker 10 years back? If you have the record, you identify that patient and you just check out every year he is coming to follow up and whether he has developed any symptoms of lung cancer or not. Again, you are moving from cause to disease. Okay, when you combine these three types of designs, it is called as prospective and retrospective. If you are not understanding this concept, don't worry about it. But one thing you always remember that we move from cause to disease in cohort study designs, and we move from disease to the cause in case control designs. Okay, that's what it is. I have a group of people in 2015 who were smokers and non-smokers. I followed them till 2025 and try to find out that how many of them developed asthma and no asthma. I'm going to compare them and then going to prove whether smoking is a risk factor or not a risk factor with asthma. Okay, and as we were assessing the strength of association between risk factor and outcome, okay, using the odds ratio in a case control study, we estimate the strength of association in cohort study design by relative risk. You can also use odds ratio here. Please, if you want to make a note, make a note. Odds ratio is estimated in case control study. Relative risk is estimated in cohort study. But you can also use odds ratio in cohort study. You can also use odds ratio in cohort study. But remember, relative risk is not at all applicable in case control study. Okay, there is a statistical reasons to that. I don't want to get into that part of it, but there is statistical reason to that. Okay, so odds ratio equals to case control, relative risk equals to cohort. Okay, so, so again, when I'm estimating, want to see the association between HIV and TB, I got the relative risk of 1.6. The interpretation remains the same. The HIV positive patients are 1.6 times more prone to tuberculosis than HIV negative patients. Let's assume that the relative risk is just 1. So how to interpret? The HIV positive patients are equally prone to TB compared to the HIV negative. Both HIV positive and HIV negative patients are equally prone to the tuberculosis. No one is more or no one is less prone to the tuberculosis. That is how the interpretation is. One of the strongest feature of cohort study design is temporality can be established or causality can be established. You exactly know which came first, whether the HIV came first or tuberculosis came first, whether the smoking came first or the asthma came first, whether the smoking came first or cancer came first. So, and causality is a very important concept in the research. Okay. So if you want to definitely prove, then you have to opt for cohort designs. And there is no recall bias as it was there because you are just following every week or every month, you are following of the patient and collecting the data. There is no recall problems. Standardize the data collection. Every time you have a standard way of collecting the data. If you are diagnosing the, what do you say, blood microbacterium levels, then you have standard technique of doing that. You are not opting different techniques at every follow-up. You have standard technique that makes standardization of data collection. And remember here, multiple outcomes can be assessed. If you remember, I said multiple risk factors can be assessed in the case control. However, here multiple outcomes can be assessed. If you are taking a group of people with smoker, you can assess whether they develop the asthma or not. You can assess whether they develop tuberculosis or not. You can assess whether they develop oral cancer or not. So multiple outcomes can be assessed in the cohort study designs. However, multiple risk factors can be assessed in case control designs. Please make a note of that. Multiple outcomes can be assessed in cohort study designs. Multiple risk factors can be assessed in case control designs. The problem here is that attrition. When you are following a group of people for few years, then there is a high possibility that many of the patients may discontinue participation in the research. Or sometimes the researcher themselves leave the research because he loses interest or he changes the job or whatsoever. And sometimes, since it consumes too much of time and high cost, if there are less resources or financial support, you may have to stop it in between. And loss of interest from research can also a problem in cohort designs. Hence, you can find very, very, very few research uh, opt for cohort designs because it's lot of time go into it. It lots a big commitment. Until unless you don't have a very good team of experts who are committed towards research, you have a very good financial and other resource support, you cannot execute the cohort designs. Only and only if you have a very good support, you can go ahead with it. Okay, so we are done with the observational design. Till now, the researcher is just observing and making a note of that. He was not changing anything in the nature. He's just making a note of that. So, observation research, we had discussed two types. One is descriptive, another is analytical. Descriptive don't have the comparison group. Analytical has the comparison group. Descriptive group generates the hypothesis. Analytical group tests the hypothesis. Descriptive research, we have uh, case report, case series, and surveys. And in analytical, we have cross-sectional case control and cohort, and we have gone through in detail about each study designs. Now moving to the next is experimental. Here, a researcher is going to manipulate and see the outcome. And there are two types. One is randomized control trial and non-randomized control trial. In medical research, randomized control trials are considered as one of the most superior study designs or gold standard study designs. Okay. It is the final step in the research process of confirming or rejecting the hypothesis. This is the stage where you confirm or reject the hypothesis idea. You is a final stage. But remember one thing very clearly that you cannot opt the experimental designs to check the etiology of the disease, right? You cannot tell intentionally people that you smoke daily 5 cigarettes for 5 years, and I want to know whether you develop the cancer or not. That is not possible. Intentionally, you cannot do so. Okay, experimental designs are usually carried out when you want to know whether certain drug, treatment modality, preventive modality is going to help or not. I want to know whether the daily physical activity is going to control over the hypertension or not. If you can tell the people, group of people to do physical activity for 1 hour daily for 1 year and check out what is happening to the blood pressure. That is ethical and that is recommended. You can do that. Or else you can come up with a new drug and say that this is a new drug and you want to compare between the existing drug and tell a group of people to take the new drug and group of people to take the old drug and check out whether what is happening to the blood pressure in coming few months or years. So this is type of research. Experimental research is usually taken only when you are checking out the efficacy of a drug intervention, diagnostic tool, or a preventive method. The beauty of this design is that investigator has a control of the subjects who is going to be participating in the research. I want to take only 25 to 45-year-old people, should not be on medication, should not have any mental or physical disability, and etc. So you can have a strict inclusion and exclusion criteria so that you can have a control of the type of subjects you want to include in. Secondly, the intervention. Intervention is a treatment. I'm going to tell people that you have to take this drug twice daily, and this is a 500 mg drug, and you have to take it for at least 2 months without any stoppage. So you have a complete control on intervention and outcome measurement. Whatever the outcome you are measuring, let's say the blood pressure, what technique you are going to use? Are you going to use a manual sphygmomanometer or a digital blood pressure apparatus which is being used exactly to measure the outcome and the conditions under which the experiment is conducted? So what I'm trying to say here is that in this type of the research, the researcher has more control in all the variables, possible variables. And that is the reason whatever the outcome you generate from this type of research is more credible when compared to the other study designs. Basically, this study design is used to evaluate the difference between two groups or sometimes more than two groups. Okay, which is more effective, taking a drug, doing a physical activity, or doing the yoga in reducing the blood pressure among the individuals? So there are three groups, and you're going to tell them to take a drug for 1 month, do the physical activity 1 month, and third group is just do the meditation and yoga for 1 month, and then check out what is happening to the outcome. So this is the purpose, and is considered the gold standard to demonstrate the safety and efficacy of new treatment. And as I said, there are two types: randomized control trials and non-randomized control trials. Okay. Whenever you are planning to take up the randomized control trials, or even for that matter, the non-randomized control trials, these four things has to be clearly defined. Most of the research faces issues because researchers fail to plan these four components. Many a times we have seen that, because I am a statistical consultant also, so whenever I do statistical consultancy, I find that many of the researchers, even for the senior researchers, are not clear about these four components, and they face a lot of issues at the later stages and find it difficult to publish or justify the research they have carried on. So please, it's a very humble request for the postgraduate students and faculty members to take these four components very seriously. Who are your patients? You cannot just say that tuberculosis patients will be included in the research. If you're telling a tuberculosis patient, how are you going to be diagnosing them? Are you just going to diagnose them with the clinical features or in some laboratory findings? Which is more reliable? Use that. Are you going to include all age group people, or are we going to include some certain age group people? Are you going to include the tuberculosis patient with other comorbidities like diabetes mellitus, etc., or not? Whatever you are including, you have should be a scientific reason behind it. So there should be clear inclusion and exclusion criteria with a scientific justification for each inclusion and exclusion criteria. You cannot tell that, so it was there in a reference article, that is the reason I'm including this. If you're doing that, then you are mistaking it. See, it doesn't matter. Like what I'm trying to say is that being, if you are postgraduate student, sometimes you feel that whatever is being published is correct and appropriate as a result published. No, you find many problems in the published research also, and sometimes it's not a problem. Sometimes even objective research is completely different when compared to what has been published. So you have to define your own inclusion criteria and exclusion criteria. Coming to the intervention, so if I tell you going to tell compare between the physical activity. I'm going to compare with the meditation and then with a drug. So the physical activity, 1 hour physical activity, you have to define what you mean by 1 hour physical activity. He has to jog, he has to walk, or he has to go to the gym or whatever it is. That definition has to be clearly defined and taught to the participants so that everybody follows the same protocol. It's not that somebody is following 1 year as a walking and someone else is jogging, someone else is going to gym. No. Then it causes a confounding in the research. Comparison group. See, intervention group is a group where you are testing the new drug or new intervention. Comparison group is a group where you want to compare with the existing established gold standard drug. Okay. And what exactly the outcome you're going to measure. I'm going to measure the uh, Mycobacterium tuberculosis levels in the blood level. That becomes a specific. At what time interval are you going to measure it? Are you going to measure it after 1 month, 2 months, or 3 months? That has to be specifically written. And how you going to assess the Mycobacterium tuberculosis? I don't know. Maybe you have a different test to do that. You have to decide one standard method of assessing the tuberculosis. And then, how are you going to measure? Are you going to measure the bacteria present or absent? Or are you going to measure it in some numerical values? That has to be planned beforehand. So please make a note that population of the participants, intervention, that is a new treatment, comparison, that is the existing treatment, and the outcome has to be clearly defined for your research. Only and only when you are clear with this research, step into the experimental group, be it randomized control trial or be it the non-randomized control. Okay. One of the important component why randomized control trials are considered superior to any other study design is because, once again, any other study design is because there is a process called randomization. What is randomization? Once again, let's understand one by one. Let's understand how a randomized control trial is designed. Basically, you have a target population in the sense you want to, whenever you complete your research, you're going to extrapolate or generalize the results to the people. Let's say you are doing a research on a tuberculosis patient. So the people suffering from tuberculosis in the globe is become a target population. And you have certain eligibility criteria in sense selection criteria, inclusion, exclusion criteria. And among the target population, you have taken people who have tuberculosis but with no other comorbidities. They are age group and so and so. They are living in some urban sector and etc. etc. So you have something, and you have selected from target population sampling frame. And there are, let's say, there's so many people who are, let's say, there are 1,000 people who are eligible to participate in your research. But for your research, you require only 100 people because your estimation, sample size estimation is just 100. So out of the 1,000, you're going to select the 100. How you will do that? By something called as random selection. You have to randomly pick it. It's not that somebody, you want to include them, or somebody who visits your hospital, you include them. No. Out of that 1,000 people, you have to randomly pick 100 people. That's called as random selection or sampling technique. And that 100 people is allocated randomly to two groups, group A and group B. Group B is a control group, group A is the intervention group. Intervention group is the new treatment, control group is the existing treatment. The important component of randomized control trial is random allocation. So here, the subjects are allocated using some boundary technique to study group and control group, and then you're going to follow up them for a certain period of time to whether check out whether there is an improvement or no improvement, and compare between study and control, come to know whether the drug has really beneficial effect over the existing drug or not. Coming to randomization or random allocation, as I earlier said that randomized control trials are considered gold standard for one of the important component that it has got random allocation. It prevents selection bias. See, researchers should not have any. Let's say you have a group of 100 tuberculosis patients, and how you divide them into study group and control group? Just by chance. You don't want researchers to decide because researchers are most of the times are biased. He will take relatively healthy people and put it into the intervention group as a new drug, and relatively people with a poor prognosis or less compliance, the patients in a control group, and tries to prove that study group is better than a control group. To avoid this problem, we have a different techniques of randomly allocating subjects in study and control group, that so that we prevent something called selection bias. And it is also observed that if you are randomly allocating the people to the study group and control group, you can overcome lot of confounders between the study and control group. The another important exercise we do it in randomized control trial is blinding. What is blinding? If you are giving a new drug and an old drug to the patient, so the patient should not be knowing which is a new drug or which is the old drug. He is blinded. And sometimes even researchers is blinded. He doesn't know whether, uh, let's say you are giving the two bottles, and there is a group A bottle and group B bottle. The researcher should not know that whether group A consists of new drug or bottle B consists of a new drug. Why we do that? Because to overcome the selection bias, to overcome the investigator bias, to overcome the participant bias. So that is process is called blinding. Single blinding is either the participants or the researcher are blinded. Double blinding is both subjects and investigators, both are blinded. Only at the end of the research, the researcher is informed that group A was a new drug, group B was a control group. So this way, you can overcome with the investigator bias and the participant bias. Another is manipulation. As I said to you that it is experimental research design where a researcher manipulates the nature. Manipulation can be of addition of something, removal of something. Giving a drug can also be an intervention, or stopping a drug can also be an intervention. So anything you are changing in the nature becomes manipulation. The beautiful part of experimental design is that you can precisely manipulate an independent variable for all the patients. You can tell all the patients take the so much dosage of drug so frequently and etc. There's the beauty of controlling the independent variable in the experimental designs. And RCT is considered gold standard. As I just said to you that you have control about allocation because you are randomly allocating. You can overcome the selection bias and also the confounding bias. The process called as blinding, where both researchers as well as the participants can be blinded, so that if they do not know to which group they belong to, they cannot have their personal choices, and it's not going to influence the outcome. And thirdly, you can have complete control over the independent variable. You can have control over manipulation, so that you can exactly prove the cause and effect outcome. If I give 100 mg, what is the outcome? If I give the 500 mg, what is the outcome? It easily comes to know with the experimental designs. Okay. There are two major types. There are more than 10 study designs of randomized control trials. I'm not going to get into it. And there are two designs which is popular. One is called as parallel group randomized control designs and crossover randomized control design. In parallel group, we have two groups or more than two groups. We randomly allocate the subjects to group one, group two, follow them over a period of time, and measure the outcome and compare that outcome between the study group and control group. This is conventional parallel group randomized control trial. Most of the research designs follow this design only. The another design is that there's called a crossover randomized control trial. What is crossover randomized control trial? Where in the beginning, the stage one or phase one, the group one will receive the new treatment and group two will receive the control treatment. And then you measure the outcome, whatever the outcome you're looking for. Then we'll wait for some time. That process is called as washout period. And later on, the group one will receive the control treatment. Now she has shifted. Instead of new, it is a control treatment, and group two will receive the new treatment, and then you're going to compare. That becomes a crossover design. The beauty of the crossover design is that both the groups are getting both the treatment. So all the confounders are getting nullified. But remember that crossover designs, please make a note of that. The crossover designs can only and only perform on those conditions which are reversible. What is reversible? Let's say that. Which is more effective in reducing the fever among the children? Paracetamol or ibugesic? That's what is the purpose of fever research. And what you do is you take a children who are like a 5-year-old something and divide them into group 1 and group 2. Group 1 receives the paracetamol, group 2 receives the ibugesic. And then you assess after 5 days what is happening to the fever. And then you give the washer period, like say few months. And again, if some stage, if these people develop the fever again, then in the group 1, you give them the ibugesic, and in group 2, you give the paracetamol and check out what is happening to the temperature levels. So this way, both the groups are receiving both the interventions, and by then you are removing all the confounding variables and measuring the outcome. So another golden rule of thumb is that whenever you can do the crossover designs, don't do the parallel group designs, but make sure that the condition is reversible, the outcome variable is reversible, right? The, the next component of experimental design is the non-randomized control trial. The very basic difference between randomized and non-randomized is that in non-randomized control trials, there is no random allocation. The subjects are intentionally allocated to study group and control group by the researcher. That's why if your faculty want to do a research on checking out what is happening to the nutritional supplements in the food by adding into the food, cooking food, and the faculty will do is one hostel mess in where they will intentionally add some supplement, another hostel mess they will intentionally don't add that supplement. So it is not a random allocation. It is like a non-randomized controlled trial. And generally, this type of research evidence generated from non-randomized controlled trial are of considered to be weak when compared to randomized controlled trial because there is possibility of high amount of confounding here. Okay, so therefore the credibility generated from non-randomized is lesser. So whenever you can do the randomized controlled trial, don't do non-randomized controlled trial. So there are different types of design. Sometimes like pre and post without control design. Let's say now we are doing experiment itself. You might have got a pre-webinar questionnaire. We have filled it. Okay, there's a pre-intervention, and after you attended the webinar, and again the same questionnaire is going to be given to you and ask you to solve it. That is pre and post without any comparison group. There is no comparison group as such. However, we can also do pre and post with control designs. One group will receive the webinar, another group will receive only the information in the form of PDF format. So you're going to compare who is getting the more information or who is getting the more knowledge. So that becomes a with control and without control designs. Okay. Remember this, the ideal research designs for finding out the etiology or risk factor is observational. In the observational, it is cohort design. That's what I said to you. However, you want to check out the efficacy of a treatment or efficacy of a diagnostic tool, then you have to opt for experimental. In the experimental, you should always opt for randomized control designs. This is something you should all remember whenever it depends what type of topic you are taking up. Depending on the topic, you have to decide the designs. And not only the topic, but also the resources, the commitment you want to put in. Okay. So if you, I'm going to share this with faculty. If you want, you can take a screenshot or a picture of this thing. This, I explained you so much of different designs, and you may forget few things, whatever I explained you. And if you want to go back and write your protocols or carry out your research and etc., or write a manuscript on the different designs, you can go through this checklist, a standard checklist for different designs. Like consort checklist is meant for randomized controlled trials. The strobe checklist is meant for case control, cohort, and cross sectionals. And Prisma is meant for systematic review and meta-analysis. and care checklist is meant for case reports. So just in case if you want taking up different topics and you may forget what is being taught over here, and you want to go point by point, then you can go to this checklist, and they are very extensive, elaborative checklist, and it will explain you every point, and you can follow those points to avoid any errors in your research. Okay, so I conclude today's lecture, okay, with summarizing what's been discussed in this past 1.5 hours. We discussed why research designs are required, what are different types of the research are there, what are different types of variables, that is independent, dependent, and confounding variable. We discussed that designs are basically classified broadly into observational and experimental. You have to opt the observational when you're planning for etiology. You have to opt for experimental when you're thinking of checking out the efficacy of a drug or a diagnostic test. And when you are opting for observational research, if the topic is relatively new, then you go with the descriptive designs where you have options case report, case series, and surveys. If the topic is bit mature, already research has been done on that, then you better go with analytical research, which is cross-sectional, case control, and cohort. If you ask me which is the most ideal, then cohort is the most ideal. You know why? Because you have a better control of all the variables, and you can establish the temporality. Temporality is nothing but the causality which came first. And later on, you have the experimental study designs, which is the you choose it to prove whether a drug or intervention or treatment or diagnostic tool is effective or not effective. And you have the two designs. One is randomized and non-randomized controlled trials. And in randomized controlled trials are considered a gold standard because of few features. That is, one is random allocation. You can allocate randomly subjects to the study group and control group so that you can overcome the selection bias and something called as confidence. You can have a blinding exercise where you can blind participants as well as the researcher so that their personal bias don't influence the outcome. You can have a better control over the independent variable. You can decide what exactly the dosage of a drug you want to give it and how you're going to measure the outcome. You can standardize that. That is the reason you can establish cause and effect more better in these study designs. When you cannot give with the randomized control trials, you have alternative, something called as non-randomized control trials where there is no random allocation. Under non-randomized, we have with control, without control. Okay, so these are the very basic study designs which are taught you here. And there, if you are interested in it, and if you want to study, there is a book called as Leon Gordis, Leon Gordis. He's a Leon Gordis is the author, and the book name is Epidemiology. If you want, you can go through that book for many more designs and understand these concepts better. There is another book called as Basic Research Methodology by World Health Organization. If you want to understand it, you can read even this book. And anyways, I'm going to share this PPT if you are interested, and you can use it for your own understanding. Okay. So I conclude this lecture, and I'll take up if there are any queries in between. And I thank Dr. Pratima ma'am for giving me this opportunity. And I thank each one of you uh, for attending this webinar online. And I hope you all got at least a basic idea about the different research designs, their usages. And I thank the institution who provided this platform, a digital platform, for organizing this event. And wish you all a very exciting, happy, and fruitful research journey which you are taking up in coming time. Thank you. Thank you, everyone.
Thank you so much, sir. The session was absolutely amazing, sir. Thanks for giving us so much information, and thanks for accepting our invite, sir. And audience, from the audience side, if you have any questions, you can raise your questions.
Hi, Umesh.
Yes, ma'am. Hello.
Umesh,
Good
it's
morning, ma'am.
Pratibha here. Yeah, my voice is not that great today, a bit of cold. Um,
I understand.
yeah, I joined about 15, 20 minutes late, but thank you so much, Umesh. It was exactly what we wanted for our postgraduates. And I hope it's exactly what many who attended the session would have also wanted to. As a postgraduate, many years ago, I always used to be very intimidated with the casual use of terms, okay,
Hmm.
odds ratio or relative risk, confounding, and then it becomes very intimidating. Sometimes we feel very shy. Oh, I don't even know the basics. I don't even know what an independent or a dependent variable is. I don't understand what a cause and outcome. And so it was my dream to listen to somebody who would, start from the basics, consider the learner a very simple person waiting there to listen to the concepts. And I think you did absolute justice to it, Umesh.
Thank you.
Thank you so much. And look at you, 10:29 dot, you completed the session. For me, it is a joy to listen to you always. Thank you
You are
so
not
much.
you are not known for that, ma'am.
Yeah.
For completing on time.
Absolutely, yes. And then you got exactly what was needed, and I think the students benefited. I'll not stand between you and the students. If they have any questions, I encourage you to ask, sir, and clarify. I also request Divya to put up the post-test form so we can see that one little study design that you beautifully explained as an example in the non-randomized control. And we also have a feedback form. So we'll
Yes,
share the
ma'am.
feedback with you, Umesh.
Please.
And we've asked a question of what are the sessions that they would like to listen to in the upcoming days. So we'll get back to you and we'll follow it up with you also.
Yes, ma'am.
Yeah. Thank you so much, Umesh. It's such a
Thank
joy
you, ma'am.
to accept it to talk to our students. Yeah.
It's a privilege, ma'am. Always a privilege to me.
Thank you. There are some questions, Umesh. Is there
Is
any
it?
limitation of sample size in cohort study?
Uh, See, sample size depends on what outcome you are measuring. This has nothing to do with the cohort design or a case control. Basically, whenever we do a cohort design, we compare between the two groups. If the difference is big, you require less sample size. If the difference is less, you require bigger sample size. Basically, it depends on a lot of statistical factors and nothing to do with much with the cohort or a case control design.
Any other questions? Umesh, there's another question. Can we define PICO for an observational study also, sir?
Uh, Doctor, in observational study design, that is coming to the analytical designs, we have something called as PEO, not PICO, but PEO. P for stands for population, E stands for exposure. Let's say exposure is smoking, and O stands for outcome. Let's say lung cancer. We don't have intervention and comparison in analytical study designs. So there you can go with PEO for observational designs.
Any other questions? Okay. At what stage of planning should sample size calculation influence the choice of design?
Generally speaking, design has got what do you say lesser influence on the sample size. Let's say that if you're doing the experimental designs, and if you're asking me like you're going with parallel group or go with a crossover, when you're going with a crossover, you will have a very less sample size when you're going with the parallel group. So those special conditions, your designs have some influence on the sample size. But let's say that generally descriptive surveys, if you're doing some survey, it is like 500 and 1000 something like that, depending on the again condition. See, if you are checking out the prevalence of a condition which is rare, which is happening in 1 in 1000, then you require a very big sample size, something in lakhs. But if you're looking for a condition which is common, like tuberculosis, maybe 10 in 100, then you require less sample size. So it depends on the condition, how prevalent it is there. Less prevalent, more sample size, more prevalent, less sample size. So that is where maybe, ma'am, when we have our next sessions, we can think about not about how to estimate a sample size, but what exactly the significance of sample size and how it is going to affect the outcome. We can have it in the next sessions whenever, if possible.
Sure, Umesh, definitely. Any further questions? You can also unmute yourself and ask a question, or you can type it out in the chat box. Okay, Divya, if there are no further questions, maybe we can conclude.
Yes, ma'am.
Should we ask people to just, turn their videos on so that we can take a picture? Okay, so that's Divya's touch, I guess. Yeah, Umesh, I thanked you enough. I forgot to thank Divya. Thank you so much, Divya, for taking care of all the fine details,
Thank you.
for communicating with Umesh, for getting everything ready from the registration form, coordinating the pre-test, post-test, the feedback. I thank Dr. Parthasarathi, a senior resident, for helping out with Divya, since most of the department members are also attending another program simultaneously. Thank our department secretary for creating the Google Meet platform and starting it on time and all the formalities that are done. Thanks to the participants. I was talking to Umesh yesterday that the programs this year in our department have been made voluntary and with a little modest payment. This was one of our efforts to ensure commitment to, committing your time, committing your willingness to learning something more than usual, equipping yourself in something, and committing your time to be there at that particular time and learn it also. It was very encouraging to see 54 registrations from across the country. And I also felt it could be because of the topic. And so we look forward to doing more sessions in the coming days with Umesh. And we have some fabulous friends, Umesh also, who are equally talented and in sharing a lot of information with us. So thank you, participants, for trusting us and joining. And I think, Divya, could you, close the session, dear?
Ma'am, shall I end the session, ma'am?
Yes.
The post test and the feedback link is also shared in the WhatsApp group, so you can fill it from there as well. Thank you so much, sir. Thank you, ma'am, for giving the opportunity to coordinate the whole event. Thank you, ma'am.
Pleasure, dear. Should we take a photograph, all of us?
Yes, ma'am.
Yeah, proof of, the perils of documentation that haunt us. Yeah.
Right.
Participants, can you please turn on your camera?
And Divya, you should stop sharing the screen.
Yes, ma'am, I'll stop.
Yes.
I'll also stop it.
Yeah. Have you pinned any screen, Divya?
Yes, ma'am. Sir,
Yeah, I pinned it off. Oh, yeah. Nice to see you, participants. If you can turn the videos on, then we could get a picture clicked quickly. Okay, smile, everybody. Right. Thank you very much for your precious time and participation. Thank you, Umesh. Thank you, Divya.
Thank you, ma'am.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am. Thank you. Thank you. Thank you. Thank you.
We'll end the call, ma'am.
Yes, yeah, yes, yes. Bye, Umesh. Bye-bye.